Thank you for watching this preparation video for Homes Clinic. Many volunteers have found that speaking with patients who are homeless can involve sensitive topics that come up throughout the encounter, especially during the social history. In this presentation, we will introduce information on some of these potential topics and suggest ways to handle this conversation with grace. First, we will discuss tips for communication, then social history items, then information regarding homelessness, and finally, specific tactics for addressing trauma, violence, and suicidal ideation. These are some general communication tips for discussing difficult topics with patients. Remember that you are having a conversation with the patient and keep questions open-ended to facilitate this. Focus not just on the words that you're saying, but also your tone and body language. Address the patient's concern while maintaining boundaries and avoiding judgmental language. Keep these helpful phrases in mind for your encounters. I cannot imagine. That sounds very difficult, and I wish things were different for you. Try to avoid phrases that feel instinctive but really are not helpful. For example, saying, "I'm sorry, I feel your pain, and I understand what you're going through," may help you feel better, but may come off as ingenuine if you have not been homeless yourself.
There's a lot to cover in terms of social history with patients at homes. Aim to cover insurance status, sleeping situation, the risk factors or situation that led to them becoming homeless, their employment status and history, and any sources of income. Some of these topics may come up when you are taking the HPI. Try to stay focused on getting the HPI, but note and come back during the social history. For example, you can say, "Earlier you mentioned X. Would you be willing to tell me more about that? It is no problem if you would prefer not to." The social history should also include discussion of the patient's educational background, substance use history, and withdrawal symptoms if appropriate. Next, cover relationships, family situation, and support network. Then, ask about history of violence and do a brief psych history. This should include questions about mood, stress levels, suicidal or homicidal ideation, and any hallucinations. Finally, you can screen for human trafficking with questions such as, "Have you been forced to do work of a sexual nature?" If this screen is positive, encourage the patient to go to the Ben Taub ER to speak with the human trafficking team case manager. These discussions are important for many reasons. Individuals experiencing homelessness are more likely to have experienced trauma, adverse childhood experiences, and/or domestic violence, which puts them at increased risk for experiencing physical abuse, sexual abuse, mental illness, and death by suicide.
Now we will discuss some strategies for providing compassionate and informed care to our patients facing homelessness. Many patients who are homeless have had previous negative experiences with healthcare settings. In light of this, it's important to give positive feedback, emphasize partnership, and listen humbly. To do this, use person-first language. A patient is never described as a homeless person, but rather a person facing or a person experiencing homelessness. Also consider the patient's environment. Ask about what they do for transportation, where they're sleeping, or how they can communicate with medical providers. Also ask about shelter rules. Many places may have a curfew or have limited access to outside foods or refrigeration, all of which may impact a patient's ability to participate in their care. Your treatment plan should reflect these limitations. While performing a physical exam, keep in mind any sensitive experiences uncovered during the history. Always tell a patient what to expect, check in frequently, and have a chaperone present or someone the patient trusts when possible. Early in the interview, assess the patient's understanding of their own health. Patients who are experiencing homelessness have higher rates of intellectual disability, mental illness, and traumatic brain injury. However, this does not mean that you should assume that someone has low health literacy or low IQ simply because they're experiencing homelessness. Finally, we've listed a few medical topics that are of particular relevance in populations experiencing homelessness. Consider discussing these topics with your patients during clinic. Though a discussion on psychiatric therapy for PTSD is beyond the scope of this lesson, there are a few points that can be helpful for our volunteers at homes. The first step for a trauma victim is to establish safety. This helps restore control to the patient. As with all of medicine, our golden rule is to do no harm. Don't re-traumatize the victim. Rather, allow your patients to share their own story, and don't push them to share more than they're comfortable. However, if they do decide to recount past trauma, our goal is to first establish a safe environment. Patients in unsafe situations should be directed to community resources in an effort to remove them from immediate danger. Homes leadership can be especially helpful in connecting patients with these resources. Trauma may also manifest physically as patients try and obtain control over their own body. Look for things like how they're eating and sleeping, any flashbacks or self-harm, all of which should be documented in the medical record and may be treated with medical therapy. Violence can occur in any sort of relationship. However, patients will not likely disclose a history of violence spontaneously. Therefore, we recommend routine screening. The questions in Table 1 are a great way to start. If a patient does disclose a history of violence, Remind them that what happened to them is not their fault. Reaffirm that they have a right to be safe and to feel respected. Then, assess their current situation. Are they and their family safe? If a patient is in a life-threatening situation or if minors are involved, you will likely be required to report the situation to the authorities. Consider what the medical care team can do to help with any physical, mental, or sexual health needs that are identified. Finally, discuss patients' interest in changing their situation. Would they be willing to go to a shelter? What's keeping them in this situation? Do they have a safety plan if things are getting worse? If patients are interested in diving into more details, consider referring them to resources such as the Houston Area Women's Center or a home social worker who's available during the week.
When you are speaking with a patient who is struggling with depression, significant trauma, or a major life adjustment, it may be necessary to assess for suicidal ideation, or SI. While many psychiatric disorders can be treated on an outpatient basis, active SI is a reason for hospitalization, so it's important to screen properly. Don't shy away from asking these questions. Research has shown that there is no causative relationship between asking about SI and actual deaths by suicide. First, inquire about passive SI, then proceed to ask about active suicidality with more direct questions such as, do you currently want to end your own life? If someone is actively suicidal, it's important to assess if they have a plan for how they would actually commit suicide. A person who already has the pills at home with the plan is at a greater risk than someone who wants to shoot themselves but has no access to a firearm. Lastly, based on positive answers to previous questions, you may assess for other risk factors for SI. If you are concerned about the immediate safety of a patient, make sure to give this information to a supervisor so they can assess if the patient is in need of hospitalization. Lastly, it's important to recognize that having these discussions with patients can also make an impact on healthcare providers. If you do have concerns related to your own reflections on these interactions, reach out to the student and staff leaders at Homes. They're there to help. Thank you very much for watching and for volunteering at Homes.